Hello everyone, Kent Bressler here. I want to welcome you to Kent's Kidney Stories. During our time together over these podcasts, I'd like to discuss kidney disease. I'd like to tell you about my journey as a transplant patient, but also talk about dialysis, kidney donation, and just about anything else that might be of interest. Kent's Kidney Stories, a podcast endorsed and sponsored by kidneysolutions.org.
Hello, everyone. This is Kent Bressler. We're going to be doing some podcasting. It's afternoon where I am. I don't know what it is where you are, but we've changed the daylight savings time. I want to make sure everybody remembers that. And as always, I'd like to prepare our way here for this podcast with prayer. Lord, being unwell, it can be so lonely and challenging. We pray for comfort and strength during times of illness. Surround us with caring and compassionate souls who can offer support and encouragement. Let us find solace in your loving embrace, knowing that you are with us through every step of our healing journey. Thank you for being our ever-present source of comfort. Allow us the safety and comfort that you can provide in life, especially as those go on the transplant programs and on the waiting lists. Think of them always, guide them always, and Lord, bring more transplants to this universe. We ask this all in your powerful name. Amen.
Amen.
So I have a great guest today, but I wanted to mention the support group. Our support group on Monday nights has grown just astronomically. We are at right now, and then I'm a numbers person, maybe this is something you can grasp, but we've gone from 14 or 15 people up into at times where we've had 45 to 50 people. Now you may think that may be chaotic. It might be, but you better come and figure it out yourself. Come on in. And all you need to do is go on to kidneysolutions.org, and there's a place that you can sign up. And we'll take care of it, and we'll get you an invite to come in. Enough said about Kidney Solutions. I'm considering a really close friend now because we're starting to do more and more things together. And the fellow's name is Zachary Sutton. He has his doctorate in health administration, and he's been a PA, a physician's assistant. But what's significant about this gentleman is that what he's doing in the kidney world is he donated a kidney. We'll talk to him about that in just a minute. He's at the Medical University of South Carolina, and he is doing some tremendous things. And I want to focus on those today, but we're going to talk to him about donating an organ. And so, Zachary, welcome, buddy. Good to see you.
Well, thank you. I appreciate it. And I think it's important to hit on one of your points. I've been involved with your support group. Unfortunately, I wasn't able to log in last night, but you're exactly right. What's going on there is short of amazing. Both the support you all provide, positive stories, bouncing ideas off of each other. I mean, that is a godsend for the patients involved. I've seen it firsthand.
You have an open invitation to dance in anytime you want to. I mean, we don't have to invite you. You're invited at all because you bring a flavor to this whole situation, a very solid, well-spoken narrative to kidney disease. It's very easy to understand. And when people ask you questions in your clinical sense, it's astounding how quickly you can come up with an answer that makes sense and people understand. And that's what kidney patients look for. And I know you've known that throughout your career because you're focusing on kidney patients. You're working with them daily. Is that correct?
Yeah, Yeah, I work in transplant outreach. So I take care of primarily kidney transplant patients, but honestly, my the way I talk about things goes back to my training as a physician assistant. I had a Air Force physician assistant train me, and one of the things that he made clear to us, he says that we use a lot of big words,
Yes.
and most patients aren't going to understand those big words. So we got to figure out ways to chop up those big words. We got to figure out ways to make those big words digestible. And one of the things he taught us throughout training is think about explaining it to a parent or a grandparent. Use the same terms that you would use when you talk to them. And that's really the way I treat patients. I treat them as if they're my family member. There's no reason for me to use giant words if it's not necessary. And if I don't make sure that the patient understands something, then I'm not doing my job. So that's a big aspect.
Big words can get us in trouble, can't they? Especially with people that have a condition that's not going to go away. All right. So,
Yes.
and I think that's lost on a lot of people, that this kidney disease is something that once you're diagnosed, it sticks with you for the rest of your life. And so the sooner you can get diagnosed, the better off you are.
And that's not to say that I only speak down to my patients. My job is education.
Mm-hmm.
So my job is to start with those small words, build up to those big words. And most of my patients, by the time they get to the point where they are further down the road from transplant, they're using the big words. They understand what they mean. So that's really the important aspect of it. I work with patients both pre-transplant. So I see patients on dialysis that are either waitlisted, or we're actively out doing lobby days, things like that, trying to recruit patients, all the way post-transplant. And in my clinic, I primarily take care of patients that are greater than a year post-transplant. And then for our transplant center, which is in Charleston, South Carolina, I am about 4 hours away physically. I'm one of the only off-site practice physician assistants in the state of South Carolina. I don't physically have a doctor at my location. And so what that allows me to do is that allows our transplant program to follow our longer-term stable patients locally without forcing the patient to drive back 4 hours to Charleston. And
you do that virtually, right? Isn't that virtually?
Well, I do virtual too.
Okay, so this is add-on to virtual. Okay.
Yeah, but I'm physically 4 hours away from my transplant center, one of the furthest points in South Carolina.
Gee.
And that greatly saves patients in time and resources. We do labs on site. We also have physicians who travel up. We have a lung transplant surgeon, a liver transplant surgeon, as well as a heart transplant surgeon who does a heart failure clinic at our location as well. So really the whole gambit of transplant, but primarily I work in adult kidney transplant. So
Okay, so what is your practice notorious for? Is it, like you said, adults, but are you talking rare disease or all disease, or
it's all kidney transplant patients. So
okay.
Unfortunately in South Carolina, most of our patients are coming to us with diabetes and hypertension.
Yep.
Being the cause of their kidney disease. We do get some intrinsic kidney disease, some adult polycystic kidney disease. We get some of the congenital diseases as either pediatric transplants age, like obstructive uropathy, things like that, or kidney disease from children. So it's a whole gambit. We don't necessarily specialize. If you have a kidney transplant and you're stable, we have a protocol now that implements both telehealth as well as our transplant outreach sites to follow up patients locally so they don't necessarily have to physically come back. And then what that does for our main transplant program is it offsets some of these stable patients so that we're able to take better care of the acute patients. And then our waiting rooms have fewer people. And since COVID, that has been a godsend.
Yeah.
We're able to better coordinate care. In many cases, a lot of our transplant patients may wind up diabetic. So we offer endocrinology services from our location. virtually. And so we're able to deliver something that in our area there's a critical shortage of. So it's really
It took me 37 years to get to that point. I just got diagnosed yesterday. I knew it was there, and so I'm just starting to follow up, starting to get some, help. I'm not going to go down that rabbit trail though. Let's stay focused on
Well,
the program.
I heard your last podcast, and the steroids, they're that double-edged sword.
Yeah.
We got to have them, unfortunately, and until something better comes along, we're set with that. We see new onset diabetes after transplant in roughly about 40 to 50% of
Is that right?
patients. Yeah.
See, like I said, it's taken me this long to work my way up to it, and and it's not out of hand, but it's something that transplant patients need to realize that if you're going to take these medicines like you should and could and do, you're gonna progress that way. It's good to think about doing some preemptive things to not get there, because if you can help it.
Yeah, and we really got to double down. I see so many patients make the mistake. We have what's called the transplant honeymoon, right? You go from that renal diet, either that CKD diet, hopefully, or that dialysis diet, to all bets being off, and it's like getting married all over again. You got wedding cake in the fridge, you got 3 meals a day, you got all the tomatoes are back, everything's back on the menu, and you really got to be careful and say, hey, let's keep an eye on your weight, let's think about the long term, and then of course people age. I mean,
oh gosh, yeah.
As we hit 60, you have an increased risk of diabetes. As our younger patients transition from their 20s to their 30s and 40s, they have an increased risk of diabetes. As our teenagers, transition and grow and start to become adults, they get larger and they have that increased opportunity, move out of the house, start, eating their own foods, choosing their own choices. So really that education needs to be throughout. And that's a really big thing that I believe in is diet. Food is medicine. I really double down and stress that to my patients. And really longer term, a lot of these secondary issues, we're very good at taking care of transplant issues. We're very good with dealing with rejection. We're very good with dealing with infection. We're very good with BK virus. We're not as good with weight gain. We're not as good with getting patients to follow up on their colonoscopies, on their mammograms. And in many cases, we should be asking those questions every time. We should be monitoring that weight. We should be updating that health maintenance. All those things become our responsibility when we immunosuppress a patient and increase the risk of diabetes and increase the risk of bone disease because of steroids and increase the risk of certain types of cancer because of immunosuppression. We really have to follow up those things long term and not think about, we're sometimes so focused on the organ, right? All of our outcomes tend to be
exactly
the organ.
Yeah.
But remember, it's a patient who gets a kidney transplant, not just a kidney. There's a patient tied there,
right?
And so we've got to be deliberate in that.
Longevity in kidney transplant. I speak to that because at 74 years old, I've had mine for 37 years. But I can tell you, it's been a pleasure to have it because I have been able to take care of it. But the point that you do get older. As you get older, things start wearing out. And just because you have a transplant doesn't mean that you're not going to have other issues. Just like you stated, you can talk about having some aneurysmal problems in your heart, or you can have abdominal ache. There's nothing that's nothing sacred. Everything is open and you can get it. All right. So having a transplant, yeah, it gets your kidney function back, but you got to pay attention. And as a patient, you really have to be the one that drives the thing. You need to be driving this whole program. And so just because you go to see a nephrologist doesn't mean you shouldn't be taking up your PCP program and getting all the things taken care of. And those are individual things, and they get more and more as you age. All of those medical issues. So yeah, the point's well taken. You know, in South Carolina, you have you have kind of like an organization now, right? It's a coalition. It's an attempt. Explain a little bit about what you're doing in this coalition. It interests me. You got a Facebook page starting up, and kind of give me some background here.
Yeah, let me start with let me say the giants who have come before me. So in South Carolina, the Medical University of South Carolina was the only transplant program in the state up until just a couple of years ago. And we had a couple of groups doing a lot of really good work. Of course, our OPO in the state, We Are Sharing Hope. We have Donate Life South Carolina, which was instrumental in actually kind of activating me at a young age related to transplant. We have a really great group of people who were former transplant patients themselves. They started a Transplant Talk SC group, which was kind of a support group where they did mentoring. And then our model in South Carolina was actually an out-of-state group called the Georgia Transplant Foundation.
Yeah.
They were a patient-started group. They involve all the transplant centers from the state of Georgia. But we have a lot of Georgia residents who come to South Carolina for kidney transplant. And over the years, the Georgia Transplant Foundation has been great, providing financial assistance, doing education, and then supporting those patients from Georgia who get transplanted in South Carolina, financially, educationally, kind of the whole gambit. And this whole time over these years, we had some groups doing good work, but everybody was kind of loosely affiliated through the only transplant program. And then just the last couple of years, Prisma Health, which is here locally in Greenville in the upstate of South Carolina, they started a transplant program. After allocation changes, our program started a second program in Lancaster, South Carolina, which is just below Charlotte, North Carolina. And so now we find ourselves with transplants happening all over our state. We find ourselves with multiple people involved with transplants. And that really brought about the need for the South Carolina Transplant Foundation. And what we're doing is just like the Georgia Transplant Foundation, we're involving all the transplant programs. We're getting the local nephrologists involved, right? Nephrologists now are getting paid a stipend for their patients who get listed and transplanted, as well as dialysis units are getting a reimbursement. So we're really trying to bring the whole gambit, whether that's private industry, pharmaceutical companies, laboratory companies, private dialysis units, local nephrologist groups, either privately or hospital owned, the transplant programs. We're trying to bring everybody together and say, hey, we're here for a common cause. The cause is to support South Carolina patients that are transplanted. Our first and ultimate goal for this year is to provide financial assistance to kidney transplant patients. Of course, kidney transplants happen the most in South Carolina. And so that's our first goal. Our second goal in the future is going to be to add liver, heart, lung, add other organs. And then in the future, beyond financial incentives, adding things like social support, mentorship, like we talked about what Kidney Solutions does so good, education, advocacy, awareness, all those things that we can do to improve the situation for all patients who require a transplant in South Carolina. It's not just my work. There are numerous other professionals who kind of had this same idea. I think what it took, though, is it took some people to come together and say, hey, everybody's got a great idea. I can think back to the iPod, and I had an idea to create an iPod, but of course I wasn't in a position to create an iPod, and digital MP3 players hit the market and they became the rage.
Yeah.
I'm in a position to create a transplant foundation. And after we kept kind of passing the buck, a couple of us got together, one of my former physicians who's the head of the Prisma program, and then one of our social workers who actually works at our second transplant program in Lancaster. And we got together and said, hey, let's do this. Let's make this a reality. We pulled in that Transplant Talk SC group. We're working with our OPO. We're working with Donate Life South Carolina. We're working with all the transplant centers, all the hospitals, the nephrology groups, and essentially we're bringing everyone to the table. And that's where we're starting. The second part is fundraising. And then really the third part's going to be starting to hand out some cash to patients.
Yep. That to me is the goal here. And I saw that when you first talked to me about this thing. And when from the state of Texas, we have several hospitals in the state of Texas. I mean, I can't even name them, but you're kind of like in a pocket. You're like in a really great pocket. You can do some really good things, and the patients are really going to benefit. Most of the hospitals in Texas, transplant programs now I'm talking about, they're independent practitioners, I call them. Very, very little, let's get together and talk, if you will. Very little, if any, right? Seminars and stuff like that where the docs get together. But if you take a transplant program, they're very competitive. You have to be honest with it. And that is just it's not a good way to handle things, I don't think, but that's been instilled in it. And that has created, I think, some issues that confound our access problem, okay, and our funding problem. Would you look at that compared to what you're doing right now? That's what we need to be doing, but we're a long ways from that, okay, a long ways.
Yeah, I think the competition aspect is a huge thing. I don't know how intentional it truly is. It's necessity though, right? These
sure, it's numbers.
Hospitals are businesses. They have boards to answer to. They may be for profit. They may be not for profit. They may be kind of a hybrid.
You bet.
But at the end of the day, they're looking at their total number of transplants. They're looking at their bottom line, their number of providers, their number of patients, their number of waitlisted patients, and they're having to make economic decisions.
Yep.
The amazing thing about a not-for-profit, though, if you do it right, if you get everyone involved, everyone to the table, we can cross many of these relationships. So, for example, a not-for-profit hospital may have trouble talking to a pharmaceutical company, right? Because the conflict of interest there.
Right.
However, if that pharmaceutical company got involved with a not-for-profit, they could donate, they could educate, they could have some connections, and we can really not only benefit the transplant centers themselves, but more importantly, benefit the patients. And I think in many cases, historically, we've always thought of these relationships between businesses and healthcare as a negative thing, right? As paying people to go out to dinner, paying to use this drug, trying to influence someone's decision. Well, again, that stuff, it happens. There are laws, there are regulations against how that can happen, how it can happen. The important thing is, though, is, if this stuff does happen, how do we make it benefit patients? Keep it legal, follow the rules, follow the regulations. But at the same time, how do we get it to benefit patients?
Yes.
In many cases, reality is, let's say reality is gray. We can be unrealistic and we can say, no, reality is white. Or we can say, no, reality is much, much darker. It's black. At the end of the day, though, it's somewhere in between. It's a little gray. But we need people to navigate that. We need people to be able to solicit donations from private companies, the public, hospitals, from anyone involved. And to be essentially, our motto is patients first, to not be biased.
That's correct.
The only bias I have is I'm going to help patients.
Yep.
And at the end of the day, that's the ultimate goal. And I think in the future, what you're going to see is that you're going to see transplant states or states where groups come together and groups work together to better maximize patient outcomes. You're going to see them do better. And really, OPOs sometimes do a good job. Of course, like in your state, you might have multiple OPOs.
Yep.
And then we get into OPOs competing against OPOs.
Absolutely. It's competition.
And so then it's just another layer. And so really that's our goal, is to kind of go above and beyond that, focus on the patients and really do this for patients.
See, I think that's what rubbed us right, you and I, when we first started. It is a matter of focusing on patients. Once you've lost that focus and you're looking at numbers and you're looking at competition and you're looking how to be better than the next guy around the block, you lose focus on what the benefit is to the patient. If you lose that focus, you're in the wrong business. And we've talked about that on occasions in our support group. Why is it that certain transplant teams seem to operate better than others? Well, I mean, there's multiple things that go into that. But when people talk about a transplant program like taking too long or being, slow and methodical, there are a lot of things that go into it. But this whole idea of competition at some point in time has got to take a back seat to the patient. The sooner, the better.
Yeah, I agree. Yeah.
So I like what you're doing there. Kidney Solutions is all in. I'm going to tell you, whatever we can provide and help you with, we're more than happy to do it. And we have some very talented people in our support group that not only through education, but I'm talking about people who've had years of experience dealing with kidney disease. And that's why we built our support program. And that's why we're running our mentoring program through our support group. Most of the people on our support group are mentoring patients early in, preemptively. We're focusing on preemptive transplant. So things like that, all the things that you've done and your group is doing, it's moving in the right direction. You're in a good lane. You need to stay there and really focus on it. So we're here to help.
Well, awesome. Well, thank you. Well,
so go. What's on your mind? You got a thought that just went by? I saw it go through your eyes.
Well, I was going to say, one of the things that we were going to, kind of talk about tonight was my donation and kind of how I got here. And really that this is, what kind of flashed through my mind here is my story of donation and advocacy. I kind of came full circle multiple times in my life to transplant. When I was a kid, one of my friends, actually, his little brother was hit by a car at our school, and they donated his organs. And I believe it or not, without having proper education, I was under the impression that something bad had happened. They had taken his organs. That when he left in the ambulance and he wound up having his organs sent all over, that clearly something nefarious had happened. And it led to me at 16, or at 15, when I got my permit in South Carolina, putting down that I didn't want to be an organ donor. Oh. And thankfully in South Carolina, we had Donate for Life at the time that did education. And one of the things in my driver's training class, a little educational video as part of our driver's training, was about signing up to be an organ donor. And, of course, it hit on some of the aspects. You're learning how to drive. Younger people who first start driving, they're at an increased risk of an accident. And that sometimes when they die, they have the ability to donate their organs and help other people. And, I still remember, you could help up to 16 people, if you die and donate your organ. And that little video, from 15 to 16, learning how to drive, I went back and I signed up for my driver's license, and I checked that box to be an organ donor at 16. And then that was it. It was out of sight, out of mind. I didn't think about it very much. In South Carolina, when I was in college, Donate for Life sponsored our triathlons. And I did a lot of cycling events and triathlons. And I would go and talk to them and I would say, hey, I saw your video. I saw your little thing on the video and it made me sign up to be an organ donor. And I started working with Donate Life. And at some point, I started to do some volunteering at some of their booths at some of our races. And, these cycling events we would get in triathlon events, we'd get young and healthy people, right?
Yes, absolutely.
Sign up to be organ donors. And those were just the people you would want. And so that had kind of an impression on me. And I would say that was probably a big part. That and Big Brothers Big Sisters was a big part of my volunteerism in my 20s and my college years. And flash forward, I had a friend that had a kidney injury at the time and might need a transplant. And so a couple of us said, hey, we would sign up, we would do it. He actually wound up, he was only on dialysis for a short period of time, and he actually wound up getting better, not requiring a kidney transplant.
Okay.
He got off of dialysis. And so I really hadn't thought much about it. And then at my college graduation, my grandmother was bipolar for a number of years on lithium for 50 plus years. She wound up at the end of her life, though, on renal failure, on dialysis. My mom had just had, this was 2002 when I was graduating from college. My mom had just had her second knee replacement, was on blood thinners, wasn't supposed to travel. And, we find out in May that my grandmother is, refusing dialysis, may only have like a week to live. And so we made the decision at that time to load my mom up, take her to Kentucky. I missed my college graduation, and we got there just in time to see my grandmother pass. And to be with her. And so really it was a no-brainer when I wound up going to the Medical University of South Carolina. The very first day there, I walked past the transplant building. I went inside and I said, hey, I want to see a transplant. And they were like, we never had anybody who just walked in. They're like, are you a student here? And I was like, well, I'm doing some research here. I said, I'll be a student here in about 6 months. I said, but I want to see a transplant. I had these events in my life and, I want to see what it's about. And I went, and one of the surgeon that actually showed me the transplant was amazing. Kind of gave me everything you would want to know in an hour and a half. It was, I believe it was actually the first kind of full abdominal surgery that I had ever seen.
Yeah.
And it was amazing. The end of it, I told them that day I was going to donate. I went on and started PA school. It took a little while. But the end of that year, in 2008, I became the first altruistic donor in the state of South Carolina to donate to the list, right after I finished my last exam for PA school.
You did off the list. You said it was non-directed, and
yep.
Do you know who the recipient was?
I do, yes, sir. I do. I got to meet him, honestly, I quickly was thrust into something that I was not prepared for. They, of course, the dean came by and, the president, and they used me in an email to faculty and staff, and look at what he did right before Christmas, and a little newfound fame, kind of all this stuff kind of hitting at once. I did the Transplant Speaker International training, just news stories. And I'll be honest, I wasn't prepared for that aspect. But what really kind of did it for me, I was on a rotation down in Florida, and a girl that had kidney disease, her family put on a bike ride. And of course, I'm a big cyclist, and I was like, I got to do this. And I emailed them and I said, hey, I'm a living donor from South Carolina. I want to come. And they were like, yeah, it would be great. We'll have you speak. And I get there, and there are just hundreds of people. And many of these patients are on dialysis, or they have liver disease, or they've already had a transplant. And then all of a sudden, that's where the rubber met the road. That's where they talk about imposter syndrome.
Yeah.
And I had it. I was like, what I did paled in comparison to what these people live every day.
Yep. Yep.
And I did not feel worthy. I did not feel that advocacy was right for me. Looking at my situation in life, college graduate, master's degree, I was a PA, all these things that had come about, all the great things that had happened to me. And I look at the people that are afflicted with kidney disease or liver disease or heart disease, and I just couldn't do it. And so really, I graduated from PA school and I quietly went to work in orthopedics. Only a few times I popped my head up in the transplant community. I think Dr. Baliga, the head of our transplant program, invited me back to a winter dinner to speak about my donation. And he had told me, he said, I'm going to get you one day. One day you're going to work for us.
Yeah.
And I said, no. I said, I'm good. I said, and I really didn't talk about it. And it really wasn't until I don't really speak about it because it's not my story, but my donor, or I should say my recipient, had a bad outcome. And it was really learning that, knowing that I changed my viewpoint, because the story I tell today, I used to, like the day I went to that bike ride, I got up there to tell my story, to tell who I am, to tell why I do this. And that's not why I do this. I do this for him. My story has been easy. My life has been good. I have not had major adversity. He did.
Yeah.
His short life had a lot of it. And my advocacy is not about me. I may be an imposter. I don't know.
No, you're carrying the torch. You're carrying the torch.
I know one thing. He was not.
Yeah.
And that's why I do this. That's why I help my patients. That's why I am so focused on this and dedicated to this. And I think in many cases, a lot of us fear doing something and maybe not doing it well, or doing something and doing it half-heartedly, doing something and having somebody tell you didn't do a good job. We just need somebody to do something.
Exactly. We need somebody to step up.
Yeah. And so many of these patients, sometimes you see a patient in clinic and you have other responsibilities and you have other patients to see and you have other, and we always find a reason. We always find a reason to either limit our interaction or not follow up with that person, or not make sure that person got what they needed. And I'm thankfully in a position now with my clinic where if I need more time with a patient,
you take it.
I'll spend an hour. Yeah.
I'll
push back my other patients. I'll find a free afternoon and I'll move that patient to an afternoon and we'll take the time. If a patient has something going on locally, a charity event trying to raise funds for his transplant, if it's within an hour and I can get there,
you're going to do
it. And so many things like that, again, I was afraid of myself failing. And it's not about me.
No,
it really isn't. And so really so much of what I do now, just by having that mindset, it allows me to do these things. It allows me to, I'll be honest, I don't like getting up talking in front of people. I've taught for a number of years. I've, led in organizations. But really where I feel most comfortable is in the one-on-one environment. And so when I talk to a large group, I do the old thing, you find one person,
focus on them,
kind of key out. And I talk to that person.
Yeah.
And I don't focus on the other people that are staring at me. I sometimes you may find the kind of that fake person and imagine you're your mom and dad or somebody there,
Yeah.
but just focus on that person and talk to that person. And that has served me well. I'm not the kind of person that likes to be on stage, that likes to be on the limelight, but somebody has to do it.
Yeah,
And
you
then,
got to step up.
yeah,
You
yeah,
got to step up,
and then when I
Zach.
look at my voice and I look at my story, I have a presence that has been afforded to me.
Yep.
You know, my dad was a college professor. My mom was more of a volunteer, casserole ministry, took care of people, but really I utilized both of those skill sets.
Yep.
You know, I utilized the teaching aspect, I utilized the educational aspect, and then at the same time I used my mother's ministry of ministering to people individually, helping random people, buying people groceries, taking people food, praying for people. I mean, I tell people all the time, I wouldn't be the person I am if I didn't have both of them. So
Yep. Servants of the Lord,
yeah,
passing only here to be better for what's coming. And I see that in you, Zach. And whatever we can do, we're gonna come back again. We're gonna do some more of this. This is more important to me than anything, and I appreciate the candor, number one, but the humility. All right, there's a lot of people in this world that lack humility, and that's a shame because they could do so much. But you talk about donors. If we just could get half or two times more than we have, we wouldn't have to worry about putting people on dialysis. If we could approach and spend the money that's spent to go to the moon, like we did, on getting people jazzed up to donate a kidney, what a wonderful world this would be. You fit in that pocket. You have a sense of history, number one, but you're authentic. And so let's just say when we meet again, we're going to do some more work and we're going to make this thing go in South Carolina. I want to be part of it.
yeah, yeah. I think that sounds great, and you know, that is one of the things that I think that we undersell enough, is that aspect, kind of like your group does, is living donation.
Yeah.
And
Mm,
you know, I always tell my patients, right, it's you know, the living donation touches so many people. You know, we get the living donation, number one. The deceased donation you would have gotten goes to someone else. And then we don't have too many positive stories in this world,
mm,
but we get that halo effect. And that halo effect reaches, maybe it's 0.1, maybe it's 0.3, maybe it's as strong as 0.5 if it's a really publicized news story, but it reaches other people and it puts that bug in their ear.
exactly.
And
Exactly.
then in the future, when it's their turn, when they hear somebody scream out, when they see someone in need, they step up.
That's
And
right.
and the amplification is so much bigger. Just in South Carolina alone, you know, right after, probably 6 months after I donated, there was a story, and they had called me and wanted me to meet a guy who was donating the kidney to a young girl, and he had said, "I read your story, you know,
Yeah.
I
See,
read your
there you
story,
go.
and I saw it could be done."
Yeah.
And
Yeah.
that was amazing to me. Then, you know, other people that I became involved with that I knew previously, I know two other people that I had direct connection to that went on to become living donors.
Yeah.
And so that's been the amazing thing. And then for me to come back to Transplant and to be able to work with people, to be able to help people, I've been involved with so many news stories. If you just Google my name in Transplant, where we've been able to help people. And
Yeah.
specifically,
Yeah.
a lot of it has to do with, you know, I could have just done the usual thing. All right, get listed at multiple transplant centers, go find a living donor, have a good afternoon, we'll be in touch.
Yeah.
But I spend more time on that. I talk about car signs, I talk about Facebook, I talk about Instagram, fundraisers. If you're not into those things, find somebody in your life.
That's what we do at Kidney Solutions.
Get them to amplify, get them to share it. Do you know anybody that you used to work with that knows somebody at the news organization or the local newspaper? And I really try to hit those topics with every patient, and not just every reevaluation. Every year I tell them, I say, if all you've got to do is wait, who are you telling about your kidney disease? Who have you reached out to? Where have you shared it?
Right.
And I'll make patients. I'll say, show me your Facebook page. Show me what you've done. And if they can't, well, okay, well, let's come up with
then we'll help you do it.
Yeah.
We're gonna close with a story that it just came this last week. Matter of fact, just a couple of days ago, I got this call from a guy, about 7 months ago, and not in this community. It's in Texas. And for some reason, as I was going through my accounts, my database, this name banged into my head. All right, for some reason, and then so I thought, well, I need to call this guy. So I looked at his record and I called him up and I said, "Say, how's it going? I haven't talked to you for a while, and you haven't called me. So where are we? What have we done for you? Where are we going with you? What have you done?" Well, he said, I know I was supposed to get my picture and a biography to you, and one thing after another. And I said, well, that's okay. So I said, I noticed that your son has been around the situation, and I see his name popping up. His name is, X, and he said, yeah. I said, well, I think I'm going to give him a call and see if he can help you really get injected into this thing. Really, start doing it, right? In other words, getting in your lane and pushing on the foot feet. So he said, yeah, it'll be fine. So I called the kid up, and he's got his own business. And he said, the first thing out of his mouth was, my dad won't let me give him my kidney. He won't let me donate to him. I said, okay, I understand that. I get it completely, because you're his son. You're his thing. He doesn't want to put you in any jeopardy, because he's probably listened to a lot of people tell him how tough it is to be a living donor. And I said to him, would you mind me going back and talking to your dad and telling him that I think it would be a wise idea if he would talk to you about you being the donor? Long story short, guess what happened? He tested the next day. He's in testing right now, and he's probably going to be his donor.
Yeah.
See what I'm saying? Mm-hmm. You connect with that kind of thing. If you don't ask it, you'll never find it. And if you don't ask, people can't pray for you. That's simple. If they don't know your condition, what you're going through, how sick you are, and what you need a kidney donor. They're not going to pray for you, and they're never going to be able to help you. You got to help yourself before others will help you. And that's the way you've lived this, though. It's wonderful.
Yeah. And the second argument is, let's say it didn't work out for him.
Yeah.
By telling people, by sharing it, though, maybe we got the son tested. Maybe we found something with the son that we didn't know.
Sure.
Maybe we educate other people in the family about kidney disease. Maybe we reach his neighbors and let them know, help them fundraise, help them when he gets his deceased donor transplant. He's got people to pray for him, people to mow his grass, walk his dog. I mean, there's so much a bigger impact than just you as an individual. And I think in many cases, our stories, we look for winners and losers in a story.
Yeah.
And we center the story on ourselves. And sometimes we've got to be able to step back and look at this bigger picture. And what I always tell patients when they have that, why me? Flip that question. Why not you?
Yeah.
Why are all these other people getting living donors Why are all these other people getting transplanted, not waiting, having good outcomes? Why not you? And sometimes we just got to change that mindset.
I think that's the whole picture here. Living donation, and you talk about it in the transplant community, there's not enough of it. That's why we don't do it. And that's not right. That's why we should do even more. All right. If we would just increase it by 10 or 15%, look at how many more transplants we could do. And healthy transplants, right? We're not talking about finding somebody that's, they're not going to transplant a bad kidney. It just doesn't, it's not going to happen. And you have to accept the fact that, yeah, you're going to probably reject more than we would like, but in a living situation, it's the best of all worlds. And we don't concentrate. All we talk about is marching somebody to dialysis, number one. And number two is, well, why don't we get started and talk to them about a transplant? Now, there has to be a major emphasis from the center, from the top out, saying living donation is a good thing and you need to consider it, and here's why. And just go from there.
And with a lot of my patients, we've got to go beyond just who the patient knows.
Oh gosh, yeah.
In South Carolina, like I said, Donate Life South Carolina used to sponsor our triathlons, and you see all these healthy, obsessed people who, I'll be honest, I've been hit by 2 cars biking, 1 car running. Had some good friends hit and killed biking.
Yeah, no.
Cycling's a dangerous sport.
Oh yeah.
I mean, we have dangerous roads in South Carolina, and I stress so many times, we need to be out in the community recruiting living donors. We need to be sharing this message at every point, every place. We need to educate high school students and middle school students. I think back to when I was 15 and I said no. And I tell people that are close to me now that I said no at 15, and they're like, how is that possible? You're the most pro-transplant person ever.
No, and you developed that though.
Nobody had told me. Nobody educated me. The only thing I had in my mind was from when I was 7 and a friend of mine's little brother died. It just amazes me, and that's what we're fighting. That's what we're dealing with.
Yeah.
Transplant centers, so many times, right? We focus our outreach on nephrologists, on dialysis units, but hey, we should be advertising general public. We should be targeting young, healthy people. We should be going to college campuses, high school, doing education about organ donation. And we could really, like you said, if we focused on this like the moon, we could really turn the tide.
Exactly. We're going to have to do that. That's what's going to come. That's what has to come. We have to do that. All right, my pal, my friend, my dear friend, what a wonderful podcast. I appreciate you tremendously. We're going to do some more of this. And like I said, I want to focus on the patient. Maybe we can drag one of your good patients in here and get him to tell or her to tell a story too. And you can tell your patients that I do podcasts like this with patients who want to tell their story. No problem. All they got to do is ask.
Yeah, well, I have a couple of patients in mind that
bring them on. Bring them on. We'll do this. All right, I'm gonna fold it up. I'm gonna put the chairs away, and I'm gonna put a stop to it. How's that sound to you?
That sounds great.
Thanks a lot. Okay, folks, I guess you know exactly what we're talking about here when we talk about kidney solutions. But let's just think about one thing for sure. If you don't ask, you'll never get an answer, and no one will ever know. Okay. And if that's the way you want to carry yourself, that's a shame on you. What we want to do is make sure you understand that we'll help you at Kidney Solutions to ask. We won't ask for you, but we'll get you geared up to where that's all you'll want to do is tell people about kidney disease and the need for a kidney donor. So give us a call at Kidney Solutions, 830-285-2140, or go to kidneysolutions.org. And until we meet again, keep breathing.